Cover briefly about the follow-up of the treatment. This is in the early stage lung carcinoma with the curative intent treatment. So what is the surveillance and what are the important things we need to monitor? So that apart from treatment, these are the one of the most important thing which we most of us neglect. So we have to be aware. So what are the topics I'm going to cover? So lung cancer surveillance. So what is the frequency of surveillance imaging and optimal imaging modality and any patient factors to be considered, like performance status or age limits which would preclude the surveillance, any role of biomarkers in surveillance, and any role of brain imaging in surveillance, both in non-small cell and small cell, and watch for the chronic complications and what are the steps we need to handle them. So who are the patients who are eligible? So for individuals who are willing for or fit for oncological treatment if recurrent. So provided they're fit, then we have to go for surveillance, and not for those who are on advanced disease or on active treatment. So there is no point of surveillance or no question of surveillance for them. So remember, so who are only fit for oncological treatment if recurrent. So coming to the first question or query, imaging. What is the optimal imaging modality? So there is no no clear evidence showing survival benefit of re-imaging. So, but the rationale, then what? Why do you need to do the imaging? So, but the rationale is to detect the recurrent disease, second primary lung cancers, and other smoking-related malignancies. So, the early interventions can increase survival, often offer curative retreatment, and improves quality of life in asymptomatic and early cases if we could detect. But as such, there is no survival benefit of re-imaging. So, what is the frequency and modality? So, the patient should usually undergo surveillance imaging for recurrence every 6 months for 2 years. That's for recurrence. But for the new primary detection, patient should undergo surveillance imaging for detection of new primary lung cancers annually after first 2 years. So the first 2 years, it will be more of the recurrence, and later it will be more of the second primaries. So that's about the non-small cell. Come to small cell lung carcinoma, no proper randomized trials or high quality data establishing the role of imaging for surveillance, but just clinical examination 3 monthly with careful assessment of signs and symptoms of recurrence, which should guide the need for symptom directed imaging. But the postulated utility of surveillance in small cell, which includes early recurrence detection for potential clinical trial participation. As you have limited options, so possibly the potential clinical trial participation and patient reassurance are important for screening. So come to brief literature. So there are few studies like McMurray et al. And Subramaniam et al. So both these studies demonstrated no difference in survival when comparing groups subjected to follow-up CT surveillance at 3 months, 6 months and 12 months interval after definitive surgical therapy for stage 1, 2, 3 non-small cell lung carcinoma. And come to Subramaniam et al. Similar study which confirmed in more than 2,400 patients with stage 1 the absence of any significant effect on survival caused by difference in frequency of post-op CT surveillance. But however, in asymptomatic patients, the second study led to detection of 63% of local regional recurrences, 37% of distant recurrences, and 72% of new primaries. And coming to one good meta-analysis by Kalman, which evaluated a survival with intensive follow-up versus a non-intensive follow-up, which intensive follow-up includes medical examination plus routine imaging, while non-intensive just includes medical examination alone. So there is a non-significant trend for improved survival with intensive follow-up, which includes routine surveillance imaging, and asymptomatic recurrences detected with the routine imaging was associated with increased survival. Yeah. So this is one prospective randomized trial, which we see not so common prospective trials we have, but this is one good trial, which 1700 patients with resected stage 1, 2, 3 non-small cell cancers, subjected to clinical examination plus X-ray every 6 monthly for 2 years, then annually up to 5 years. Or clinical examination, X-ray and CT scan with plus or minus bronchoscopy at same intervals every 6 monthly for 2 years, then annually for 5 years. Then after a median follow-up of approximately 9 years, no survival benefit was seen. So next, coming to the optimum imaging modality. So few important things. Clinicians should use the diagnostic test, that is CT scan with contrast preferred, covering the adrenals, and without contrast or without contrast when conducting surveillance. And first 2 years, as we said, recurrence is predominant. So first 2 years for the recurrence, and low dose CT chest screening for new lung primaries after the first 2 years of treatment. Then should not use PET as a surveillance tool. So there is one study about the PET CT data. So after 92 patients, resected patients with PET versus standard CT and bone scan and brain MRI at 6 month interval post resection, and no improvement with PET scan, but it is not even cost effective or associated with increased radiation exposure. And after 2 years of surveillance, as we already discussed, the more our shift of surveillance moves more in favor of detecting new primaries rather than recurrences. So surveillance imaging may be omitted in patients who are clinically unsuitable or unwilling to accept further treatment. So as we discussed in the beginning, who are fit or willing for treatment, but not for those who are unfit. And A should not preclude surveillance imaging, and consideration of overall performance status, chronic medical conditions, and patient preferences are important. So coming to my fourth question, what is the role of circulating biomarkers in surveillance? Like any role of CFDNAs or any clinician should not use, as of now, there is no robust data or no strong evidence, and should not use circulating biomarkers as a surveillance strategy for detection of recurrence in patients who have undergone curative into treatment for stage 1 to 3. Several studies have demonstrated, there is few studies which have showed elevated CEA levels in post-op period which reduce survival, but not many studies have proven, and these CEA levels are not calibrated properly, or cutoff values are different, so, and also false elevations due to various conditions CEA. So as of now, CEA is not considered as one of the biomarker testing for recurrence. And next common is CFDNA, so which is presently the most promising strategy in detecting MRDs, and a platform currently recommended for genotyping for advanced stage diseases. But there is two studies where Abosh et al. And Chaudhary et al., which able to demonstrate that detection of CFDNA could predict disease progression in 72% of patients, but very small studies and very limited sample. But still, both these studies, the identification of plasma DNA, CFDNA preceded radiological diagnosis by just 2 to 5 months. So it's not reflecting the survival. So however, detecting recurrence in 2 to 5 months before imaging may not enhance survival, which is our primary endpoint. So it is not much beneficial. So as of now, until further studies are there, CFDNA is not recommended as a surveillance marker. So come to our last question, role of brain MRI for surveillance. For patients with stage 1 to 3 non-small cell, clinician should not use brain MRI for routine surveillance for recurrence in patients who have undergone curative intent treatment. But we all know patients who have undergone curative intent treatment for small cell, stage 1 to 3, and who did not receive PCI, which is not so common, but unless who did not receive PCI, clinician should offer brain MRI every 3 months for the first year and every 6 months for the second year. And same schedule may be offered for patients who did receive also. If they are symptomatic, they can be continued. And we all know incidence of brain mets in non-small cell are about 5 to 40%, and PCI has not improved any survival or quality of life in non-small cell carcinomas. But coming to the brain mets in small cell carcinomas, which are incidental, also they are high, like limited stage about 50% and even more than 60% in advanced stage. So they needs brain imaging modality. But there have been no randomized trials assessing the role of brain MRI surveillance compared with observation alone. So coming to next topic, chronic complications, what are to be monitored or what all we see. So there could be sequelae of surgery, radiotherapy, chemoimmunotherapy, and psychosocial aspects are also important. So fatigue is the most common symptom among cancer survivor patients, linked to depression, anxiety, pain, psychological distress, dyspnea and sleep disturbances, dyspnea and chronic pain. These are one of the few common things we see. The post-surgery patients. Then chemo-induced peripheral neuropathy, metabolic syndrome, and lobectomies and bilobectomies are associated with significant decline in sleep, mental functions, sexual activity and overall quality of life, and psychological distress. Cognitive impairment in few patients, not all, and sexual dysfunction, which is seen in more than 60% of patients by few studies and surveys. So next is addressing high-risk behaviors. So this is one of the important thing. Persistent tobacco use should be addressed and inquired, which are more likely to have secondary cancers. And after surgical resection with curative intent, secondary tumors are more common in 2 to 3 times more common, and recurrent tumors are 2 times more common in patients who continue to smoke. And overall mortality is about 3 times higher. And other issues, diet, limited research available, limited data, no role of diet management or anything. Weight, of course, there are few studies, but very limited evidence. Higher baseline weight and weight gain during treatment are correlated with improved outcomes, but not strong, robust data. Physical activity also similarly import a significantly better QOL and decrease pain severity. Vaccinations, often overlooked, might decrease mortality and morbidity. So respiratory vaccinations like pneumococcal influenza and COVID-19 vaccines should be taken care of in the follow-up patients. So final take-home messages are follow-up patients, post-treatment should be surveillance imaging modality to be done. Routine MRI brain scan, CFDNA, PET scan not recommended. Aggressive imaging yet to show any survival benefit. Vaccination, symptomatic care and rehabilitation should not be overlooked. Yeah. Thank you. These are my acknowledgements. I thank my teachers and institute. Thank you.